Hi, everyone. I'm Deb Flashenberg. Welcome to Yoga, Birth, Babies, a podcast produced by Prenatal Yoga Center. We will be diving into everything prenatal yoga, birth, and baby related, hoping to inspire, educate, and empower you through your journey into motherhood. Thank you for listening. Hi, I'm Deb Flashenberg. I am your host of Yoga Birth Babies, and today I have a really fun podcast conversation. I talked to Dr. Shannon Clark about the myths and realities of pregnancy and birth, and she busts some myths and she pumps up some realities. We talk about epidurals. We talk about when can you get it? When is it too late? When is it too early? Is there such a thing as too late and too early? We talk about what happens if you wake up on your back. Is it okay to sleep on your left and your right side? We talk about Group B Strep. Is it appropriate to stick a clove of garlic up your vagina? The answer is no. So we go through quite a bit of this, and I think it's going to help just demystify some myths and help you know what is reality. So let me tell you a little bit about Dr. Clark. So Shannon Clark is a double board certified obstetrician and gynecologist and maternal-fetal medicine specialist focusing on the care of women with maternal and or fetal complications of pregnancy. She also has an amazing Instagram following, Babies After 35. And if you're thinking, oh, her name sounds familiar, she was on the podcast over the summer talking about pregnancies after 35. So I'll make sure I put that in the show notes. If you want to listen to that, I will get that for you. Now, before we get to that conversation, I want to remind you that I have a free downloadable you can grab from our website, prenatalyogacenter.com, and it's 5 simple solutions to the most common pregnancy pains. So I've got a downloadable that you can grab to help alleviate some of those pains. No reason to live with them if I can help you feel better. Also, to help you feel better, we have live prenatal yoga classes 7 days a week. So if you're thinking you want to feel better, you want to be part of a community, we've got you covered. We've got class every single day. And of course, we've got postnatal and baby and me. I also want to take a moment and thank those that have left a rating and review for the podcast. It helps people find us, and I appreciate your effort. Because I know taking any extra effort nowadays can feel overwhelming, so thank you for those that have done that. And if you haven't, I ask if you have a moment to please do so. And then the last thing I just want to give you a heads up about those that are interested in deepening their practice as a yoga teacher. We've got our 85-hour prenatal yoga teacher approved to complete online work through 2021. So you no longer have to worry about traveling. You no longer have to worry about hotels, etc. We've got you covered online. And then if you don't want to go so deep into a big yoga training and you just want to maybe deepen some knowledge about, if you're a teacher, what to do when a pregnant student walks in your room, or if you're a pregnant student that's still taking open level classes, I've got a short online course for you. It's called Who's Afraid of the Pregnant Yogi. You can check that, of course, from our website or who'safraidofthepregnantyogi.com. Okay, I think we're going to take a super quick break. And when we come back, please enjoy my conversation with Shannon. She is fun. She is quick-witted. She is sharp-tongued. I think you're going to love her. All right, we'll be right back. Hi, Shannon. How are you?
I'm doing well. How are you?
I am surviving. Oh my gosh, it's a year this week that all this craziness has happened. Can you believe it?
Yes, I can. Yes, I can.
I like your honesty. Yes. So
it's been very, very real for me. So yeah.
I know. I mean, you're a doctor, you're in the hospitals. I can't even imagine what life must be like. So I appreciate you carving time. I know you're actually in the hospital right now. You have your scrubs on. So let's just jump into it. And again, I want to say thank you for giving me some time because I had such a good time talking with you about having a baby over 35. That was a great conversation.
Yeah.
All right. So I feel like I have gotten to know you a little bit from our last conversation, from watching you on social media, from just our interactions, but let's just have a little bit of your background and who you are and what led you into your profession as an OBGYN. So if you don't mind sharing a little bit about yourself.
Yeah, so I am currently a double board certified OBGYN and maternal-fetal medicine specialist at academic center, where I am a professor with roles as clinician, educator, and researcher. All this stuff I do on social media is something I do on my own time to educate. And especially during COVID, I've been very active about getting accurate information out there regarding that. But I knew my first year of residency in OBGYN that I wanted to do subspecialize and pursue a maternal-fetal medicine specialist. So now for my professional work, I just do all high-risk pregnancies where my patients either have a maternal and or fetal complication or condition in pregnancy that requires high-risk care. So that's what I do on the day-to-day here at my academic center.
Yeah, you are busy. So you are the perfect person to have this conversation. So the reason that I thought to reach out to you is because you really do have such vast knowledge. I've had students ask me questions and I feel like sometimes they're out of my lane. So I've been collecting these questions for you for the last several months. So we're going to go over some myths and realities of pregnancy and birth. So the first one, this comes up, I'd say at least once or twice a month. It's talking about sleeping on the left-hand side. I have students that will ask me in class, oh my God, I woke up on my back or I slept on my right side. I'm so scared I hurt my baby. Can you, and I try to explain the whole vena cava thing, but again, I'm not a doctor, so I want them to hear it from you. Can you talk about sleeping on the left-hand side?
Yeah. So the inferior vena cava, or the IVC, it's the largest vein of the human body. So basically it runs along your spine on the inside of your body, right alongside the aorta. So the vena cava carries the venous blood from the lower body and the abdominal pelvic region back up to the heart, whereas the aorta is what takes the oxygenated blood from your heart and supplies the rest of the body. So it completes the circuit. Okay. So why is this important? Well, it's a big vessel, and since it runs along the right side of the aorta, when we're doing a C-section or we're doing some kind of procedure, even when we're doing an ultrasound in the second and third trimester, we give the patient a little leftward tilt just to take that pressure off the inferior vena cava, because if there's pressure on it from the growing uterus, and especially as you get into the second trimester and the third trimester, I don't know if any of your listeners have ever had where they got really dizzy, lightheaded, or even nauseated when they're doing an ultrasound or an NST or something like that. Well, that's why, because the weight of the uterus kind of impairs the blood flow or impedes the blood flow from the IVC coming back up to the heart, which makes you lightheaded. So the same thing can be said when you're sleeping. As your uterus gets bigger, it gets heavier, and you typically don't want to lay flat on your back, especially in the second and third trimester, because you don't want that extra weight to be put on the IVC and make you dizzy or lightheaded even when you're laying down, or, potentially impair the blood flow going back up to the rest of the body and even the uterus and the placenta. So we just kind of recommend that you sleep on your side. It doesn't matter which side, left side, right side. They're the, second and third trimesters, for two things: just to be safe and also to keep you from freaking out, or the listener from freaking out. And I hear that all the time as well. What I did, I was pregnant with twins and I was on bed rest for 2 months from 22 to 31 weeks or so. I got one of those pregnancy pillows, like the big C-shaped body pillow, just to remind me to kind of put a tilt in. I never laid completely on one side or the other. I just kind of had a little bit of a tilt. And one day I would feel like tilting to the right, and one day I would feel like tilting to the left. So it doesn't really matter which side you tilt on. It's just ideal if you can to just avoid laying directly on your back. But if you wake up, and you find yourself there, don't panic. Likely everything is going to be just fine. But if you really want to be conscientious about it, I felt like the pillow had just helped to remind me when I was sleeping, and just kind of was there just so I wouldn't roll over completely on my back. I was a little paranoid about it too, I must admit, but I was pregnant with twins. So that's kind of what I did to make myself, or keep myself from going on my back.
And I like that you said they can sleep on either side, because sleeping on your left side, say like for 20 weeks straight, that can really screw up your alignment.
It's either side.
There we go. Little myth busting. It doesn't just have to be the left. And if you wake up on your back, just roll yourself over. You and baby are fine. Yay, we are myth busting. All right, let's talk about, I have a whole list. So the next thing I want to talk about is birthing position. So one thing that we talk a lot about in prenatal yoga is as we go through the asanas, we look at different positions that could be birthing positions. And then there's a conversation of, but my care provider said they only want me on my back. I think is the only way to birth on the back. And I say, well, I think you need to have a conversation, what the expectations are. So how would somebody go about having that conversation with their care provider about options other than just on their back?
So it's important that you start these discussions early in your pregnancy. You can add a question for each prenatal visit or a couple of questions, just to get quick, rapid fire answers. Waiting until right before delivery to throw, and I see patients do that all the time. They'll wait to the very last minute and want to get all these questions answered, and the doc may or may not have time. But if you kind of fill them throughout your pregnancy, then it's more likely you're going to get the answers as you go along. So that's the first thing I would do. I would suggest starting the conversations early. That way you can get to know your provider and what they prefer, what they don't necessarily like, how they practice. And if there's something that's really, really important to you, if being able to push squatting is that important to you, and you find out that your provider doesn't go for it, then it gives you time to find another provider. Okay. Mm-hmm. If there's any few things that are an absolute no or a deal breaker for you that if you can't do, and it could be anything, you might want to talk sooner than later to your provider about that, just in the event that they don't do that for whatever reason, or the hospital doesn't allow it. I don't know. I'm just throwing things out there. Mm-hmm. For whatever reason. That way you can find someone that can allow you to do that.
But what if someone's in a situation, sometimes finding another care provider may not be an option, depending on insurance or how late?
Well, it's how late is the issue. Because a lot of providers won't take somebody after, I've heard the most common is probably after 32 weeks, but I've even heard after 28 weeks. That's why I say
in New York, it's 23.
23 weeks.
Yeah.
And so it's different everywhere. So that's also something to consider. That's why I say if there are a few things that are, non-negotiable for you, then you might want to make sure that provider knows that from the day one, so that if they can't provide that for you, then you find somebody else. The other thing you can do is you can tour labor and delivery and talk to the nurses, because nurses are the ones that are going to be laboring with you. Okay, so laboring in different positions is also ideal. But when it comes to pushing, it may be either the nurse that pushes with you, it could be the provider that pushes with you, or whoever's delivering you. And then if you're in a teaching hospital, it could be the residents that push with you. So it's different in whatever hospital setting that you're planning on delivering in. But either way, the nurses are definitely going to have something to say about that. And I do highly recommend labor and delivery tours.
That's really smart.
When it comes to pushing, though, I think that, pushing in various positions, what we think about in a hospital setting, it can become problematic for two reasons. Number one, if continuous fetal monitoring is needed, and in a hospital setting, most of the time it's going to be needed and required, because that's what we do in the hospital. And then second, if you have an epidural. If you have an epidural, there's the walking epidurals, some places that have them. And then there's some epidurals where, yes, you have some feeling, but you can't really walk. It depends on what the hospital provides. If you have an epidural to where you can't walk, are you going to be able to get in a squatting position to push? Are you going to be able to, probably not. So those are all things to consider. So when you think about, continuous fetal monitoring, and sometimes that is needed. Okay. And in a hospital setting, that's usually going to be done. And then also if you have an epidural, that can limit your pushing positions. So those are things to discuss with your provider too. So I still think, you have to think about the big picture. If you have a complicated pregnancy and delivering in a hospital is needed for whatever reason, and then you may not have the option of pushing in a bunch of different positions, especially if you need an epidural or if you need continuous fetal monitoring. Does that make sense?
It absolutely does. I'm wondering, definitely squatting if you don't have, the sensation in your legs and they're just really heavy. But what about just being on one side? How open do you think
push?
Most?
So that's laboring, and you can also push on the side with the leg up. But when I hear about different people pushing, they're wanting to move around and push, get on the birthing balls and push and do those types of things, or pushing in the shower. I mean, there's a whole lot of different positions that you can push in and labor in, for that matter. I mean, there's a whole lot out there. Yeah. And then there's also a very negative, and I see this on social media, about pushing on your back. No patient should ever be made to push on their back. I've been delivering babies for 20 years. I deliver in a hospital. 99% of my patients push on their back, and I've never had an issue with it. Now, they may not have been interested in pushing in other positions because they are, patients that are delivering in the hospital. But that doesn't mean that we can't make compromises if they're wanting to try a different position. It all depends on what the situation is. If the mom's stable, the baby's stable, she's able to get in that position. If she does have an epidural, and so you kind of have to put all those factors together.
That makes absolute sense. So again, coming back to having a conversation ahead of time to have expectations just right out there. All right. So we started talking about epidurals, about birthing positions. Let's keep with that. So I remember when I was a doula, I had seen a wide range of answers for this. I actually had a client get an epidural at 10 centimeters, when she just didn't feel the urge to push and she was exhausted. And then I've also heard of people being denied at that point. What is the last chance to get an epidural?
So that's going to vary from patient to patient, situation to situation, and provider to provider. And you never know what's going to happen. And I'll give you an example. If I have a patient that comes in or goes from 4 to, she wasn't expecting to have it, didn't think she needed epidural or wasn't even thinking about it. And the next thing you know, she's 10 centimeters. If she's not feeling the urge to push and the baby looks okay and she's doing okay, but she just happens to be 10 centimeters, and that does happen, then we could try to get that epidural in if that's what she wants. There are things that the anesthesiologist can do to where they don't fully dose the epidural, and they can do half the medication or kind of do it a little bit differently to where she doesn't go completely numb. Okay. Now, if she gets to 10 centimeters and the baby's coming out and she needs to push, am I going to stop everything to put an epidural in? Probably not. She just needs to have a baby. So there are those situations too. So, if the baby's coming no matter what, sitting up for an epidural is probably not going to be in the best interest because the baby's still going to come. So it all depends on what the situation is. Are you 10 centimeters and the baby's ready to come out, or are you 10 centimeters and we have some time? But you can only make those decisions in that situation, and it's different for every patient.
And I think that's really important because I've had students that would come back and be like, I was told this was my last chance at like 8 centimeters or, and I say, and again, I'm like, oh, that's an interesting thing. That was again, I don't want to burst anyone's bubble, especially if they come back after their birth. I don't want to be like, oh, that's too bad that happened. Because that can make them feel badly. But I like that you're putting it out there that it depends on what's going on. Because as a doula, I had seen people 10 centimeters, baby was high, no urge to push, exhausted, and it seemed like a great idea. Get the epidural because we had a time to go. So I like that though. People now can hear if they're being, I don't want to use the word threatened, but if it's being said, this is really your last chance, maybe take a step back and evaluate. Is that what we're kind of getting at here?
No, I would ask why.
Okay.
Why is it my last chance? I mean, what's the answer going to be? If there is a legitimate answer because they think, I don't know, the baby's heart tracing doesn't look good. And I don't know. I'm just putting it
right.
I don't know. I don't know. If there's giving you an answer that you are okay with, but if they can't really give you an answer, then why? But I don't want to speak for other providers. It's hard to do that. I just think that if there's time and the patient wants it and baby's stable, the baby's not coming out and we have time to do it. And that's the same thing for how early they want them. If she wants it early, I'll give it early. It's not going to change the course of her labor. It depends on her. The only thing that getting it early though may not allow you to move around as much for a longer period of time, right? So that's one thing to consider. But ultimately, it's up to the patient and what they want. It's not my decision to determine when they're in enough pain or when they're far enough dilated to determine when they get an epidural. That's her decision or her choice, or their choice. So, I can't speak for the thing that you said that, this is the last chance you get. I don't do that.
Right.
But I would ask if that is being told to somebody that they ask why.
That's great. All right. So you said I was going to ask about the other side, like how soon, and you said whenever. Can you go over a little bit about the pros and cons of getting an epidural? You said one thing about too early, not general.
Yeah, getting it early, when you get an epidural and, you may be confined to the bed longer because you can't move around and walk around. So that's one thing to consider, but I have patients who have had sexual trauma in the past and doing exams is not ideal for them, or even placing the medications that we sometimes use to induce for whatever reason is not ideal for them. And if they want an epidural, I'll give them an epidural. I'll give them an epidural at close, thick, and high if that's what they need to get through their labor. So it's up to them. It's not my job to determine if their reason for wanting an early epidural is valid or not. It's an epidural. It's not going to change how she labors. It just might mean that she can't or they can't move around as much because they're an epidural, they have an epidural and they may not be able to walk or get up and go to the bathroom with the epidural in. So it's the only thing that really is to consider, but ultimately it's their decision.
Oh, absolutely. Yeah. We're never here to tell anyone how to birth. Because it's not it's not my place, it's not your place. So they make their choice, but that's helpful to know that, if there are reasons that you really want it early. And I totally hear sometimes I've had students that are just so much fear about what it's going to be like, and they're a perfect person to jump in earlier.
Yeah.
All right. Let's stick with the epidural topic because this has been a conversation amongst students. I've seen this on Facebook. How does the medication pass along to the baby?
So, basically epidurals, the epidural or an epidural block is kind of one of the medical terms that we use for it, is the most common type of pain relief that's used in childbirth in U.S. So we give medications, or not we, I don't. The anesthesiologists give medications through the tube that's threaded into the back that can be given, and they usually what we call dose you up or give you a higher dose at the beginning and then an infusion over time where you can push the button to give yourself little boluses throughout the course of your labor. But it's going to have a combination of analgesics, which is usually opioids, and anesthetics. So that's the medications they put into the epidural. And, the whole idea is to get you through the course of the labor, but not to make you so numb that when it comes to the time to push that you can't feel anything. Okay. So, there is an art to the epidural, and that's what the anesthesiologists are great at. So when you think about the fetal neonatal risk for epidural, those are typically related to what the maternal effects or risk are with an epidural, such as hypotension, meaning low blood pressure. I don't know, if any of your listeners have had an epidural before. A lot of times before they place the epidural, they will bolus you with fluids to get your blood volume up. They also, place the epidural, and then sometimes you might have lower blood pressures because the epidural is working, and that's one of the side effects of it. So keeping the baby on the monitor and watching for that. And sometimes the baby's heart rate will even drop down for a period of time right after the epidural. And then we resuscitate and everything comes back up okay. So that's one of the main risks. But the opioids that are in the epidural can cross the placenta, or opioids in general. So opioids can be given intravenously, or what we call the IV pain meds, and they are also given in along with the analgesics through the epidural. So opioids in general can cross the placenta, but there's definitely a much higher risk of it crossing the placenta and affecting baby if it's giving IV. Giving it through the epidural could potentially happen, but the chances are much less. So, I'm not, I remember one of my, actually I still work with him, a very superb researcher, PhD. He always tells me, Shannon, everything crosses the placenta. Everything crosses, he's a placental expert. Everything crosses the placenta. Because everybody wants to know that he says it does, and he's the expert. So I'm sure there, to some degree, opioids do cross the placenta from the epidural, but not enough that I've ever seen that it's going to cause the effects that if I had given like the IV pain meds or opioids through the vein. So there is definitely a difference.
Okay, we're going to take a quick break. When we come back, we're going to switch topics to Group B Strep. We'll be right back.
Swimsuit? Check. Sunscreen? Check. Phone charger? Check. Don't forget to pack the 5-Hour Energy. It fits great in a pocket or carry-on, and the alert feeling will help you arrive ready for anything. Now get 20% off when you use code 5HETRAVEL at 5hourenergy.com. Expires April 30th. One-time use only. Not valid with other discounts. Remember, visit 5hourenergy.com and use code 5HETRAVEL to save 20%. Looks like you need a vacation. Enter the 5-Hour Energy Where Will the Tide Take You sweepstakes. You could win a $10,000 dream beach vacation. Imagine jet setting off to a tropical paradise, having fun in the sun, or diving at a gorgeous reef. It's up to you. No purchase necessary. Go to 5HETide.com for official rules and to enter. That's 5HETide.com. Enter today. Ends June 30th, 2024.
Okay, we are back. All right, so this one makes me laugh because this was a story one of my friends told me. So is there any way to prevent Group B Strep? And the reason I asked this is because I think I put this in the notes. One of my friends stuck a clove of garlic up her vagina, and she told me what she did. She made a hole in it and put a string, so it'd be like a tampon. And she said in the morning she went to pull it out, and just the string came out. And I asked her, well, how did you get the clove out? And she said it was so high up, she had to have her husband go fish it out. Yeah. So,
we've had a few trips to the triage, for garlic removal from the vagina.
So
that does happen. Yeah.
So
it does happen.
This is a common situation or somewhat?
I would not say common, but it does happen. I've seen it more than once. Let's just put it that way.
Okay. So let's talk of the reality of that.
Okay.
And can anyone prevent Group B strep?
No. So this is what I want to clear up about Group B strep. It is a normal bacteria in the vagina. Okay. It is not pathologic. Women have it or they don't. Let me back up. When we screen for Group B strep in pregnancy, it has to be a certain threshold to screen positive, and then to treat. Okay. But it is a normal bacteria. It's not like it's a sexually transmitted disease. It's not like you need antibiotics to cure it. It's normally found in the vagina. It's just that if you get the culture and it comes back positive, we treat you in labor because we know that if you're positive and you're not treated in labor, the chances that the baby can get Group B sepsis, during the course of labor are high, and Group B sepsis is very, very severe, and we want to avoid that. So no, there is nothing you can do to prevent it. Okay.
So keep the garlic out of your vagina?
Keep the garlic out of your vagina. Yes, please do. And it's not a bad thing. I get the feeling that people feel a little stigmatized if they are GBS positive, like they did something wrong. It is not that you did anything wrong. You could be GBS positive in one pregnancy and not GBS positive in the next pregnancy. You might find that you had a urinary tract infection. And, sometimes we get urine cultures on patients for whatever reason, and it came back with some Group B strep and they had no symptoms. And that's fine. When it's in the urine, we do treat it with a course of antibiotics, and then you're considered GBS positive. You don't need the specimen, the culture that we do at 36 to 38 weeks. So, there's no reason to feel bad or negative about being GBS positive. It's just that we need to know what it is so that if you have it, so that if you are positive, we will give you the appropriate antibiotics in labor to prevent the baby getting Group B strep infection.
That's helpful. See, we're again myth busting. I've also had students ask me like, should I put yogurt in my vagina?
No, and
I would say like, no. I don't feel again appropriate to answer that, but usually I would say no to that one. So keep the food out of the vagina for Group B strep.
The food is not meant for the vagina.
All right. See, myth busting. Okay. Another one that comes up a lot is pregnancy weight gain. Yeah. Oh gosh, I've heard so much. I was very fortunate. I had a midwife and an OB, and they were really lenient. They're like, just between 25 and 30 pounds. That's kind of what we expect. And then I've had some students say their care providers kind of get on them from it. And then I've heard others say, their care providers don't put much emphasis at all. What is your take on pregnancy weight gain?
Yeah. So, we do have guidelines based on BMI, the body mass index. And I'm just going to say there's a lot of people out there that think that BMI is BS and we shouldn't be using it because it doesn't take account into different body types. I will say that, yes, I understand that point. However, we don't have a much better tool to use. So until we do, we're going to keep using the BMI, and it's not necessarily a bad thing. Okay. So basically what we do is we go through BMI, and a normal BMI is 18.5 to 24.9. And so if you're of a normal BMI pre-pregnancy, that's what you need to know what your pre-pregnancy BMI is. Then we're going to say 25 to 35 pounds in your pregnancy. If you're under a BMI of 18.5, which is considered underweight, you might want to gain more, 28 to 30 or 40 pounds. But that also depends on, some ethnicities are just smaller in general, and they're not going to gain that much weight no matter what. It doesn't necessarily mean it's going to be an unhealthy pregnancy. Okay. So we kind of keep those things in mind as your obstetrical care provider. Overweight's going to be a BMI of 25 to 29.9. In that case, we recommend a weight of 15 to 25 pounds. And then a BMI greater than or equal to 30, lower weight gain is recommended 11 to 20 pounds. And, the more it becomes more problematic when you get into the overweight and obese BMIs, because, starting at a heavier or a larger BMI pre-pregnancy and then getting pregnant is going to predispose you to things like high blood pressure, preeclampsia, diabetes, having a big baby, things like that. So we do really want to watch the body weight, how much weight gain that you have in pregnancy. And it becomes more important, in my opinion, after 20 years of doing this, when the BMI is, reaching 25 or more, especially 40 or more. That's really going to be an issue. So BMI does play a role, the pre-pregnancy BMI. We make the recommendations based on that, but it doesn't mean you have to do that. If your BMI is normal and you only gain 20 pounds, it doesn't mean your pregnancy is going to be unhealthy. Okay. You may be a more active person, and everything else is just fine. These are just guidelines. And the best thing you can do is just discuss it with your provider. As long as you're gaining weight and you're healthy, everything should be fine. But if you have any concerns, just talk to your obstetrical care provider.
From the feedback I've got from my students is it's more the other side that
What's that?
that they may feel like they're being a little chastised for gaining too much weight.
Well, I mean, I see. So if they're gaining too much, that can be problematic too, because do I think that any patient, normal BMI or not, should be gaining 50, 60, 100 pounds? No, that is not going to be good for the pregnancy in anyone. Okay. So I don't chastise anyone. I educate them. But at the end of the day, unfortunately, we can't go home with our patients, nor do you guys want us to, I'm sure. But there are potential complications. And I'll give my mom as an example. My mom was a first-time mom at 21. She gained 60 pounds in her pregnancy. And there's no question, this is 47 years ago. There's no question she was diabetic. Now, I don't think she was diagnosed. And I was a huge baby. She had bilateral mediolateral episiotomies, a forceps delivery, and hemorrhaged. So, those are, and I'm not trying to scare people, but excessive weight gain in pregnancy can be problematic. Now, I don't think anybody should be chastised or made to feel, there's a way you have to approach it as an obstetrical care provider. Mm-hmm. I tell the residents all the time, if you start out by blaming or scaring your patient, you're going to lose them. You're going to lose them. You're not going to be able to get your point across. It's more about having a conversation and a dialogue about what your concerns are, why you're concerned, and what you want for this pregnancy so that the patient and the baby can have the best outcome. That's the best way to approach it. So I hate to hear that anybody's being chastised, but I will say that excessive weight gain in a pregnancy is problematic.
Okay, thank you. And I appreciate your honesty there. All right, we're going to swing to another topic, low fluid, a reason to wait and see or induce.
Yeah, so low fluid, that's called oligohydramnios. And it's going to depend on how oligo is defined, and we'll go into that. When did it start, the timing of onset, what the placenta looks like in association with it, and any other confounding medical conditions that are going on in the pregnancy. So, for example, I'll give you an example. If you have an AFI of 5 at 37 weeks, the placenta is grade 3 and you're diabetic, you're getting delivered. Okay? Because now you have all these red flags. If you're my patient, you're getting delivered. Okay? You have all these red flags. You have a grade 3 placenta. You have diabetes on medication. You have low fluid. You're term now. I'm going to want to get you delivered. Now, if there's no other issues, and it depends, again, on how oligohydramnios is defined. Some centers define it as a deepest vertical pocket of less than 2 centimeters. So I don't know if whenever you've had an AFI done, we kind of divide the abdomen into 4 areas through the belly button. Right upper quadrant, right lower quadrant, left upper quadrant, left lower quadrant. And we do a deepest vertical pocket in each one of those quadrants. And if you cannot get a DVP in any of those quadrants or deepest vertical pocket of greater than 2, or if it's less than 2, your DVP is less than 2 in any of those quadrants, then that could be considered oligo, or if the overall total AFI is less than 5. Centers define it differently wherever you're getting delivered. So some go with the first definition, some go with the last. So if you have oligohydramnios with a DVP of less than 2 centimeters or an AFI less than 5, and you're otherwise uncomplicated, the recommendation for delivery put out by FACOG is delivery between 36 weeks and 37 weeks, 6 days. So that's the timing, give or take a few days. Okay. Do I follow that? I do. Now, if the patient is otherwise uncomplicated, has no other issues other than low fluid, I might push toward the later end, towards the 38-week mark. But if she has other complications, the placenta looks calcified, or she also has diabetes or high blood pressure or anything like that, I might go to the lower end of that window. Does that make sense?
It absolutely does. And so it just helps someone think, if they're being told low fluid, that it needs to be it's individual. It's not a blanket statement.
Yes, it's not a blanket statement. And we have a window there for a reason. The recommendation is 36 weeks to 37 weeks, 6 days for a reason, for the reasons I just stated. I'm all for getting, and this is just speaking for me, getting a patient as far along in the pregnancy as possible. As long as they don't, and I say red flags a lot. That's how I teach my residents. You got to start looking at, are there any red flags that are going along as we start trekking along in the pregnancy? What red flags is she picking up, or the patient picking up in their pregnancy? And you have to think about coexisting medical conditions and other things that are developing that will help you guide when in that window you're going to recommend delivery.
Right, so then here's another question. This is coming from my mentor that shared with me, and we're going from myth busting reality. I was taught that if there is space to wait and see, to go home, hydrate, Epsom salt bath, and see can that bring the fluid up. Is that actually a myth or is that a reality?
It's conflicting. Do I think that, okay, so let's back up. If you're below 36 weeks, I'm going to try to do everything I can to get that fluid up. I'm going to tell you to go home and hydrate, or I'm going to take you into the hospital to get you some IV fluids because I don't want to deliver. And I've had some patients that had oligohydramnios at 32 weeks. I don't want to deliver at 32 weeks. So if there's things that I can do, I'll do that. Do I really think deep in my soul that IV fluids and PO hydration works? Not so much. I'm not convinced. And the literature is kind of conflicting too. But it's not going to hurt. So why not do it? I'm going to be more aggressive about trying to do hydration, whether it's by mouth or IV, the earlier they are in pregnancy with oligohydramnios. Once you get past 36, 37 weeks, I'm not going to be aggressive. I'm not going to be a hero and try to stretch out the pregnancy, especially if there's other things going on.
But if they're pretty low risk otherwise, and there's no other red flags, and they don't want to be induced right then, and they say,
that's why we have the window.
The window, okay.
36 to 37 and 6. Say they got diagnosed at 36 weeks. Everything else looks okay. No other issues, and they want to go home and PO hydrate. Fine, as long as everything else looks okay, and then reassess the fluid level in a week. But that's just how I practice. And I'm not speaking for everybody else. What I'm saying here, I want to make sure this is not, every center has windows that we use and ways that we like to do things.
Right.
And that's why there are windows as far as when to deliver for certain complications. So I'm just saying there is some wiggle room there. My biggest piece of advice though, is if any provider says, we have to deliver you now, and they can't tell you why, they should be able to tell you why.
Yeah, then there's a problem.
Okay, so and that's fine. Ask. There's nothing wrong with asking why, and there's nothing wrong with asking, well, can I get more time? If not, why?
So what I tell my students is that they can ask the questions: am I okay? As the pregnant person, is the baby okay? Can we have more time? Because it will highlight, is there space to negotiate? Is there space
to compromise
and to have a conversation as well as, let's say, take the fear out?
Yeah.
Because if they're not told a medical reason, I can imagine that building up a lot of anxiety of like, well, what's wrong? What's wrong? Why aren't you telling me?
Well, I will say, oligohydramnios is defined as a deepest vertical pocket less than 2 centimeters or total AFI less than 5 centimeters. It is something that is not my favorite thing to address because I know that in the absence of any other issue, it makes me nervous. It makes me nervous. After 36 to 37 weeks, it makes me nervous. Even if there's no diabetes, if the placenta still looks fine, I still get nervous. I'm going to be honest with you, but I'm going to have that conversation with the patient, and, weigh the risk and the benefits, the pros and cons. If we do decide to stay pregnant, when do I want to see them back? Reassess the fluid, what they can do in the meantime, tell her to do fetal kick counts, things like that. So there are things that we can do, but I will tell you, I just had a situation the other day where a patient was between 35 and 36 weeks, and there was not a black and white answer that, whenever you deliver somebody, she needs to be delivered because of X, Y, and Z, black and white, right? But most of it was my gut. I just knew that something was not right, and I did it, and I was 125% right. And I was so glad. Sometimes we do go on our gut.
Right.
And, and that's where trusting your provider comes into. And sometimes I tell the patients that, listen, I have this, and that's what I told the patient the other day. I just have a feeling this is what's going on. Do I have it in black and white? No, I don't, but I just have a feeling. And I was right. So,
well, that's your provider, where your history comes in and your
history. And, we should be allowed a little bit of that because I've been doing it for so long. And so, sometimes we just have that feeling but if it's your provider and you trust them and you have a good relationship with them, then you should know and trust your provider. And sometimes, if they just tell you, I don't feel good about keeping you pregnant past 37 weeks with an AFI of 2, then just trust your provider.
But if it's not, so kind of going away from just the low fluid, but just in general, if someone has said, well, we have to do this now, and someone's saying, but if I'm okay, my baby's okay, can we have more time? And they're not able to give an answer.
Then it's time to compromise.
Okay. So how would that pregnant person hold that conversation? Could be like,
well, I would say, are there any alternatives? Is there anything else we can do? in the meantime, or come back and be reassessed? What are the risks and the benefits of waiting? Mm-hmm. Okay, let's talk about them. What are the risks and the benefits based on, what we do and what we do not know? I wish it was so easy to just give you a script. It's not that easy. It's not, because as obstetricians and obstetrical care providers, we have to think about two patients in one.
Right.
And unfortunately, it's not always black and white. Yeah. But I do think that there should always be room for
conversation.
If at least at the very least, conversation, if not compromise.
That's really, really helpful. Mm-hmm. So that's going to lead us into reasons for induction. And I know, I hope that's not too big. You don't have to give me every reason. But what are some reasons that someone may expect they may hear? And I'm trying to think of the best way to say this. If someone feels strongly they would rather not be induced, how do they have that conversation? Or if someone's wanting to be induced and their care provider's like, but you're fine. I don't know if that ever happens.
Oh yeah, it happens. Yeah. So let's talk about some of the more common reasons of why we as providers might recommend induction. Now, I will say per ACOG and the induction of labor or delivery before 39 weeks of pregnancy should not occur unless there is a medical indication, whether it's medical because of mom or medical because of the fetus. Okay. There should be a medical indication for anybody that's getting delivered before 39 weeks, whether that's via induction or via cesarean section or delivery for any reason. Okay. After 39 weeks, getting induced, it could be the most common things that we see, are, elevated blood pressures, preeclampsia, complications of diabetes. If there's preterm or premature rupture of membranes, other things with maternal medical diseases, like I said, diabetes, renal disease, if there's antiphospholipid syndrome, if there's things with the baby like growth restriction, low fluid is another reason. So there could be growth abnormalities of the baby. So there's tons of reasons for induction of labor. But again, inducing anybody before 39 weeks should have a medical indication. It shouldn't just be done for convenience sake. But then after 39 weeks, if there's a medical indication, there's no reason not to do it after 39 weeks. If there's no medical indication and everything is fine, any person can get induced after 39 weeks if they're okay with it. I offer, and my institution offers everyone elective induction of labor after 39 weeks if that's what they want. Mm-hmm. And there's in the absence of any other medical indication. Most of the patients go for it or want it. But that's, it's offered to them and they're talked to about it, and then they decide whether or not they want to do it. So that is something that is done as well. And that's also based on the ARRIVE trial. Mm-hmm. So, induction is, there are a lot of reasons for induction. But again, if you are uncomplicated, the baby looks great, you look great. And I hear a lot that people are getting induced just for being 35 and older. No other issue. Now, if you're after 39 weeks and you're 35 or older and you're okay with that, and you talk to your provider about it, and you've talked about the risks and the benefits and the reasons, and you want to do it, that's great. You're after 39 weeks. But, that's not a reason to deliver early based on age alone. And, you could always ask in the absence of any other issues, what would be the reason for induction?
That's really helpful. I do have a lot of clients at my studio that are over 35, and you and I talked about this before, that do feel they're put in kind of a little separate category. So I appreciate you talking about that.
I see a lot that, my provider told me that I have to be delivered at 39 weeks because I'm 35. In the absence of anything else, that is not an indication for induction. Being 39 weeks and the patient desires it is, okay, that's different, but not just for being 35. I think it's important to know that, again, there's always room for conversation, if not compromise, even after 39 weeks, if induction is not your thing.
But I like that also you addressed that someone may want to be induced just because, and I get this, I've been pregnant, you've been pregnant. Sometimes it's just like, I just want this to be done with. And then.
No, I will say an overwhelming majority of my patients, if they're offered elective induction at 39 weeks, they want it. And this is the other thing. And people don't want to, I think sometimes, especially OBGYNs get such a bad rap. We have to also consider that sometimes it's not always the provider wanting that. sometimes if you have a provider that's in a group of other people and they have a higher chance of delivering you, if you're being induced at a certain time after 39 weeks, a lot of patients want that. Mm-hmm. They want to try to have their delivery by the provider that's been seeing them. And there's nothing wrong with that. As long as it's after 39 weeks and, it's okay with the patient and the provider. Some people want to do that and not wait until they get, they have that relationship, and there's nothing wrong. There's nothing wrong with that. So sometimes getting induced, especially after 39 weeks is what the patient wants. And there's nothing wrong with that either.
Yeah, I agree. Again, this is, it's about what it's for their birth plan, what's going to, at the end of the day, satisfy them, and it's their story. Yeah. All right. Let's talk eating during labor. I promise this is my last one. I've been throwing a lot at you. All right. Let's talk about that. Eating during labor. It has changed since I have been in this whole medical world as watching people have babies. I know that general anesthesia has greatly changed since this rule has come about. Talk about that, because if someone I've actually had clients that have had very big meals and all of a sudden labor started. Granted, most of the time they threw it up. Let's talk about eating during labor.
Yeah. So if you come in labor and you just ate Whataburger. I don't know if you guys have Whataburger. And that's happened. I mean, a lot of times patients are eating a big meal and they go into labor and they come in and their stomach is full and there's nothing we can't control that. I can't say, you know what? No, hold the baby in, go back, come back in 8 hours. We just have to prepare for it. That's why anesthesia is there. And they always ask, when's the last time you ate or drank anything? And what was it? Okay. Now, if someone has a planned cesarean section or a planned induction, we're going to tell you not to eat. Okay. And that's because we have control over that and we don't want you to eat. What is the chances you're going to need a stat C-section under general anesthesia or your epidural fails and you need general? I don't know. None of us know that. We can't say you have an X% chance that your epidural is going to fail, or you have an X% chance that something's going to happen and you're going to have general anesthesia. It just happens. When it happens, There's not a whole lot of warning. When we have to do the urgent C-sections or for whatever reason, I had an epidural or spinal and it's failed and I had to have general now. And I hadn't eaten, but it was kind of quick. So, it just happens. So, if we have control and they're coming in for a planned induction or a planned cesarean section for whatever reason, and we're definitely going to say, please don't eat anything, this many hours before coming in. If it happens and there's no control over it, there's not anything we can do about it.
So what about someone that labor spontaneously begins, they're laboring away, they're getting hungry, they just want to nibble on something. What are your thoughts about that?
If I want to continue to work with anesthesia, the answer is going to be no. Now, listen, this is a hospital setting. Hospitals are hospitals. I get it. That's the only environment I've ever worked in. These are the rules that we play by, and I stand behind them. I'm not going to allow someone to eat during labor on my watch because that's not what we do. Okay. And for that reason, because what if they end up in a stat C-section? Until you have seen someone aspirate because of a full stomach, it's hard for you it might be harder for you to understand why we don't let you eat. But you see somebody aspirate on the OR table or, whatever reason, it's not a good thing to happen. And it's something that none of us want to experience because it can be very, very, very severe. Okay. So yes, is it rare? Yes, but it doesn't matter. Some of the most rarest of things in obstetrics, we want to avoid because of what the outcomes are.
Yeah,
so we have to consider that as
honesty. I've had and I've seen a range of that. I've had some care providers say you can have something like fruit or something until you have an epidural. Then after you have an epidural, I really want it to be clear fluids. It could be broths. It could be popsicles. It could be different juices. And then
we do let them drink clear liquids or water, but no eating.
Yeah, I've seen a range, and then I've had somebody like as soon as you're in the hospital, absolutely nothing. Yeah. It really seems so, I guess, care provider individualized of what their comfort level is.
It's not just that; it's also patient population individualized. Now, you're talking to a high risk obstetrician. My patient population is high risk. Okay, I'm not doing low risk on a day-to-day basis, right? So the chances that my patients end up in a cesarean section are higher because they're complicated to begin with. So that's another reason why myself and my anesthesiology team are not going to want them to eat. We have a higher risk patient population, but in a lower risk patient population that's not being managed by high risk obstetricians like myself, then they may be more lenient around that, and that's perfectly within their right.
So again, a lot of this, pretty much every question comes back to having a sense of what the expectations are from the care provider and the relationship. So it all comes back to communication with the team.
Yeah. I mean, it's important. It's, I've done this a long time. I look at the big picture. I am constantly trying to be 2 to 5 steps ahead about what could potentially happen and to be prepared for that. And again, it's because my patient population is different. They are high risk. So that's my job, is to try to predict what could potentially happen and be prepared for it, because I don't want to not be prepared. And so I always try to think about the what ifs. But like you said, we can also talk about things. I don't want to scare patients either, but if there's something that I'm starting to worry about, I might want to give them a heads up. And I've done that before. Listen, this is going on. This is what I'm concerned about. I'm just letting you know that, we might have to do this. And there's nothing wrong with that either. So, just communication is so important, between the patient and the provider, so that, neither party's left in the dark. And that goes for the patient too. If the patient's having concerns or, worries or has questions, bring it up. Don't leave us in the dark, just as much as we shouldn't leave you in the dark about what we are feeling.
I think that's great that you do talk about, not to freak you out, but I'm just keeping an eye on this, because if I was the patient, I would want to know. That way they can also mentally prepare that, I was thinking my labor is going to go this way. All right, I have to wrap my head around, we might go this way. And it just gives them a chance to get grounded with that.
Yeah.
I think that's a great way.
Yeah. But you can do that without instilling fear or being a negative. It doesn't always mean that I'm already signing her up for a certain outcome. Right. It just means it's something if it's on my mind enough to where I'm thinking about it, then I think she should know, or they should know.
I really appreciate that, about how you practice. Okay. We're going to take a quick break. When we come back, if you can offer, now you've been doing this for 20 years and you're a mother of 2 kids. So you've got some knowledge. You've got a lot of knowledge. If you can offer one tip or piece of advice for new or expectant parents, we'll be right back.
This podcast is sponsored by Skylight Frame. Mother's Day is almost here. What are you getting her? Something that shows you care. Something that makes her feel loved. Something that won't stress you out. Something like the Skylight Frame. The Skylight Frame is the perfect gift. It's a touchscreen photo frame your whole family can upload photos to, from wherever they are in the world. It's a way to share with her all the moments that matter. It sets up in seconds. You can even make sure that it's already loaded with photos when your mom opens her Mother's Day gift. And her Skylight Frame can hold thousands of the treasured photos you share. It's an easy, heartfelt way for mom to stay connected with those who matter most. It really is the perfect gift. Now, as a special Mother's Day offer for our listeners, get 15% off your purchase of a Skylight Frame when you go to skylightframe.com/easy. That's SKYLIGHTFRAME.com/easy. Get 15% off your Mother's Day purchase now at skylightframe.com/easy.
Okay. We went through a lot. And again, I really appreciate you doing this, because I feel like there's so much conversation about, I've heard this, and I like that we set the record straight. So what is a tip or piece of advice you'd like to leave new or expectant parents with?
So, this is what I always say when I'm asked this question. There is a wealth of knowledge available, a wealth of information available through social media, books, online courses, you name it. It's there. You can find information on anything, Facebook groups, mom groups, and you can find information anywhere when it comes to your pregnancy, postpartum, neonatal period, having a new baby at home. What I think is the most important thing is that you choose your providers, your obstetrical care provider, your pediatrician, because that should be the person that you primarily get your information from and the person that you should trust the most. If you feel that you're not getting that information, so much so that you're having to seek it out somewhere else, then there could be an issue there. So you need to vet your providers. I said something, people will go take their car for 5 estimates before they pick on one mechanic, but we don't do that with our OBGYNs or our pediatricians, so it's the same premise. You can start researching before you even get pregnant or early in pregnancy who your provider and even who your pediatrician is going to be. So you can see if it's somebody that you really trust and to be your primary information giver. I'm not saying that you can't go to those places for additional information, but if you're doing it because you're not trusting what you're being told by your provider, then that's more of an issue.
That's one of those red flags. if you're not trusting your provider. Because how can you go into your birth where we really do have to work as a team if you don't trust your provider? That's gonna derail.
Well, I mean, but think about it too from a provider's perspective. And it can be that the provider it's not their fault, any fault of their own. But if you're going and you're getting other information in these places, you have to understand and accept the fact that there is a lot of inaccurate and bad information out there. Mm-hmm. Just because you're getting it from somebody doesn't mean it's accurate or right. So if you are still wanting to go to those places and get information, just make sure you're consuming information that is accurate and that the person, you can vet them. You can research them online. If they're confident enough in what they're putting out that they will put it on social media, whether it's in an Instagram or whatever, you should be able to research that person and find their credentials. Mm-hmm. Okay. And what their training is. If you can't, then you might not want to get information from that person.
And that is why we're doing this podcast, to break to break our myths and find out the realities. I do appreciate this. Thank you. Okay. Where can people find your work?
Yeah. So I am on Instagram at Babies After 35. And then I'm also on TikTok at the TikTok Baby Doc. I also want to add that I have a wealth of information on COVID infection and the vaccination on my Instagram. Under my COVID highlights, I have like 7 different aspects of COVID there with, research articles and everything for people to get information that way. I've also done some live discussions. So that's kind of been what I primarily focused on over the past year.
That is great. And you are an excellent source to get information from. So I hope those listening run over to your Instagram. Your TikTok videos are hilarious.
Thank you.
You just kind of put it out there. I just started doing reels and I don't know. They have to be a little more staged for me, but you just kind of like go with it. You got the music. I don't know. I love what you put out. So
well, thank you.
Thank you also for entertaining me.
No problem. Anytime.
Well, thank you, Shannon. I really appreciate your time.
All right. Have a good day.
This has been an episode of Yoga Birth Babies, produced by Prenatal Yoga Center. You can catch us on Facebook, Twitter, Instagram, and Periscope. I'm Deb Flaschenberg. Thanks for listening.